We are going to start a series of lectures discussing early pregnancy complications. Complications in early pregnancy are ectopic pregnancy, miscarriage, gestational trophoblastic disease, hyperemesis gravidarum, recurrent miscarriage, and termination of pregnancy. Ectopic pregnancy incidence 11.1 per 1,000 pregnancies, but it actually represents 3 to 5% of patients presented to early pregnancy unit. Difference is these patients who present to the early pregnancy unit are actually referred from their GP or coming because of a complaint, which is most likely pain or bleeding, which are symptoms of ectopic pregnancy. But in general population, its percent is 11.1 per 1,000. Risk factor, any factor that delay or prevent migration of oocytes, like pelvic inflammatory disease. As you know, pelvic inflammatory disease can be complicated by adhesions, and these adhesions will delay the migration of oocytes and accordingly will lead to ectopic pregnancy, as it will lead to implantation of the fertilized ova inside the fallopian tube. Intrauterine contraceptive device, sterilization. Incidence of ectopic in sterilization is quite common. Incidence of failure of sterilization is 1 in 200, but unfortunately, if it failed, the most likely pregnancy will be an ectopic pregnancy. Tubal surgery, previous ectopic increase the risk of a recurrent ectopic, assisted reproduction, and the use of mini pills. This slide shows the sites of ectopic pregnancy. The most common is tubal, and the most common part of tubal is the ampullary, followed by the isthmus, followed by the interstitial. Other sites include ovarian ectopic pregnancy, cervical ectopic pregnancy, cesarean scar ectopic pregnancy, and an abdominal ectopic pregnancy. Clinical picture of ectopic pregnancy. The most common symptoms is abdominal or pelvic pain, amenorrhea or missed period, vaginal bleeding with or without blood clots. Other reported symptoms include breast tenderness, gastrointestinal symptoms, dizziness, fainting or syncope, shoulder tip pain, urinary symptoms, passage of tissue, rectal pressure or pain on defecation. That's why it's very important to do a pregnancy test for any woman in a childbearing period who present with any of these symptoms. And we have cases who present to emergency department with vomiting and diarrhea, and pregnancy test was missed, and we discovered that she had an ectopic after it's ruptured. So again, I have to emphasize on the idea it's very important to do a pregnancy test for any woman in a childbearing period presenting with these symptoms. Signs of ectopic pregnancy. The most common signs are pelvic tenderness, adnexal tenderness, abdominal tenderness. Other reported signs: cervical motion tenderness, or what we call cervical excitation, rebound tenderness or peritoneal signs, pallor, abdominal distension, enlarged uterus, tachycardia more than 100 beats per minute, or hypotension less than 100/60 mm G, shock or collapse, orthostatic hypotension. You have to refer to an early pregnancy assessment service or out-of-hour gynae service if early pregnancy assessment service is not available, for any woman with bleeding or other symptoms and signs of early pregnancy complication who have pain, pregnancy of 6 weeks or more, pregnancy of uncertain gestation, and the urgency of this referral will depend on the clinical condition. Investigation. First is pregnancy test, serum BHCG. Ultrasound has a cutoff value for serum BHCG. For transvaginal ultrasound scan is between 800 and 1000, and for transabdominal ultrasound scan is between 1000 and 1500. The ultrasound features include empty uterus, adnexal mass moving separate to the ovary, containing a gestational sac which can contain a yolk sac or a fetal pool, or complex inhomogeneous adnexal mass moving separate to the ovary, or collection of fluid in the uterine cavity, which we call it as pseudosac, with moderate to large amount of free fluid in the peritoneal cavity or pouch of Douglas, which might represent hemperitoneum. When carrying out transabdominal or transvaginal ultrasound scan during early pregnancy, you should scan the uterus and the adnexa to see if there is a heterotopic pregnancy. So identifying an intrauterine pregnancy cannot exclude presence of coexistent ectopic pregnancy. Therefore, it is very important in early pregnancy scan to scan both the uterus and both adnexa. BHCG and pregnancy of unknown location. As I said in the previous slide, there is a cut-off value for the ultrasound to be able to identify pregnancy. So if the BHCG is below this cut-off value, what we need to do? We need to repeat the BHCG in 48 hours. Then you have one of three scenarios. The first scenario is BHCG increase at least more than 63%. This is likely an intrauterine pregnancy, and in this case, you can provide the patient with TV scan 7 to 14 days, or earlier if the level is more than 1500. Or BHCG drop by more than 50%, is likely a miscarriage. In this case, patient should do pregnancy test in 14 days. If it is negative, there is no action to be done, as it is most likely a miscarriage. If it's still positive, it will require an urgent review. Problem will happen if the BHCG increase but less than 63% or decrease but less than 50%. In this case, it will require an urgent review. So what is the management of ectopic pregnancy? We have three lines of management of tubal ectopic pregnancy. We have expectant, medical, and surgical. For expectant management, patient should be clinically stable, pain-free, mass less than 35 mm with no visible fetal heart on TV scan, BHCG less than 1000. We can consider expectant management if BHCG is between 1000 and 1500 and patient is able to return for follow-up. And if we follow the expectant management, we should repeat BHCG in day 2, day 4, and day 7. There must be persistent drop in the BHCG. If the BHCG increase, there is no rule for expectant management, and we don't need to give the patient anti-D for expectant management. Medical management, patient should have no significant pain. It should be unruptured tubal ectopic pregnancy, mass less than 35 mm with no visible fetal heart on transvaginal scan, BHCG less than 1500. However, we can consider medical treatment in BHCG values up to 5000. Patient shouldn't have an intrauterine pregnancy, and patient should be compliant with follow-up. And in this case, we have to do BHCG on day 4, then day 7, and then weekly. We compare the ECG value between day 4 and day 7. There must be a drop at least 15%. And if this drop doesn't happen, then we have either to consider another dose of methotrexate or surgical option. And again, there is no need to give anti-D with medical management of ectopic. Surgical management is indicated for patients with significant pain, adnexal mass equal or more than 35 mm, fetal heartbeat visible on ultrasound scan, BHCG level more than or equal 5000, and methotrexate is not acceptable to the woman or unable to return to follow-up. It can be either laparotomy or laparoscopy, and laparoscopy is the preferred route because of the benefits of laparoscopy. It can be salpingectomy or salpingostomy, and it depends on the condition of the other tube. So if the other tube is healthy, then salpingectomy is the first line. However, if the other tube is removed before or diseased, then salpingostomy can be considered. If we do salpingectomy, patient need to have a pregnancy test after 3 weeks. But after salpingostomy, we have to do an HCG on day 7, then weekly. Anti-D is required in case of surgical management of ectopic in an Rh negative patient. We have to counsel the patient about the fertility potentials after salpingectomy, especially if diseased contralateral tube or previous ectopic pregnancy. There was no difference following expectant or medical management. in the rate of ectopic pregnancy, in the risk of tubal rupture, in the need for additional treatment, in the health status, depression, or anxiety scores. Please remember, methotrexate should only be offered on a first visit where there is definitive diagnosis of an ectopic pregnancy and a viable intrauterine pregnancy has been excluded. Advise women who choose methotrexate that their chance of needing further investigation and intervention is increased, and they may need to be urgently admitted if their condition deteriorates. Women receiving methotrexate will have some abdominal pain initially, will have increase in level of BHCG on day 4. They have to understand that, but at the same time, cautious should be advised in case of management of an abdominal pain following methotrexate administration for an ectopic pregnancy, as it can notify rupture of an ectopic pregnancy. When surgical treatment is indicated for a woman with an ectopic pregnancy, it should be performed laparoscopically, as we said before. Don't offer anti-D prophylaxis to women who receive solely medical management of ectopic pregnancy or miscarriage, or for a patient who has pregnancy of unknown location. There is no need to use Clay-Howard test for quantifying fetal-maternal hemorrhage. So what are the different types of ectopic pregnancy, how to diagnose and how to treat? The first one is cervical ectopic pregnancy. It is diagnosed by ultrasound showing empty uterus, barrel-shaped cervix, gestational sac present below the level of internal os, absence of sliding sign, blood flow around the sac using color Doppler. The ultrasound feature is quite diagnostic of a cervical ectopic pregnancy, and the management is mainly medical because surgical management has a high failure rate and it should be reserving only for women suffering from life-threatening hemorrhage. And unfortunately, this woman may end up having a hysterectomy. However, there are studies showing the possibility of removal of cervical ectopic pregnancy through hysteroscopic resection, other than through suction evacuation, under ultrasound guidance, or even laparoscopic guidance, and show success rate. For cesarean scar ectopic pregnancy, it's 1 in 2,000. Diagnosed again by ultrasound showing empty uterine cavity, gestational sac or solid mass of trophoblast located anteriorly at the level of the internal os, embedded at the site of previous cesarean section as shown in the slide, thin or absent layer of myometrium between the cesarean section, sac and the bladder, evidence of prominent trophoblastic/placental circulation on Doppler with empty in cervical canal. As you can see from the slide, the sac is located mainly outside of the scar between an empty uterine cavity and empty cervical canal. We don't need any biochemical investigation for diagnosis. We can use the MRI as a second line of investigation if the diagnosis is equivocal. Management is either medical or surgical, with or without hemostatic measures. There is insufficient evidence to recommend any intervention over the other. However, the current literature supports surgical rather than medical approach. With cesarean scar pregnancy, we have two different types of pregnancies. The first type would be progressing intrauterine cavity as the sac grows and develops, with potential to reach a viable gestational age, but with the risk of massive bleeding from the implantation site and the risk of placenta accreta or increta. But the second is the progression deeper towards the serosal surface of the uterus, with the risk of first trimester rupture and hemorrhage. Primary medical treatment consists of using methotrexate, which can be administered by local injection in the sac under ultrasound guidance or systemic by intramuscular injection. Local injection seems to be more effective in means of termination of pregnancy. However, use of medical management has some disadvantages, is that the trophoblasts remain in situ, so there is still risk of hemorrhage as the retained, often very vascular, placental tissue degenerate. Some authors have advocated using suction evacuation in addition to methotrexate to hasten resolution and reduce the risk of unpredictable hemorrhage in the follow-up period. Surgical treatment consists of either evacuation of pregnancy using suction or hysteroscopic resection, or excision of pregnancy as an open laparoscopic or transvaginal route. Suction evacuation is probably the most frequently described procedure, has been combined with cervical cerclage, Foley's caster, insertion of return artery embolization as an additional holistic measures. Excisional technique has a advantage of incorporating a repair of a scar because we are actually excising the scar with the pregnancy and then repairing the scar back, but the procedures are technically more difficult and invasive. Not known whether scar repair reduces the risk of recurrent scar pregnancy or scar rupture in future pregnancies. Interstitial pregnancy, it's about 1 to 6.3%, diagnosed by ultrasound showing empty uterine sac, product of conception, and gestational sac located laterally in the interstitial intramural part of the tube, surrounded by less than 5 mm of myometrium in all imaging planes as shown in the slide, with presence of the interstitial line sign as shown by the right arrow. Serum BHCG should be carried out at diagnosis, and sometimes we need a repeat one. Non-surgical management is recommended for stable interstitial pregnancy. Expectant is only suitable for women with low or significantly falling BHCG level, in whom addition of methotrexate may not improve the outcome. Methotrexate is insufficient evidence to recommend whether local or systemic approach, but it's an effective management. Surgical management includes laparoscopic corneal resection or salpingotomy. Alternative technique is hysteroscopic resection under laparoscopic or ultrasound guidance. There is insufficient evidence on the safety and complication in future pregnancies to recommend other non-surgical methods. For corneal pregnancy, it's about 1 in 76,000, so it's really quite rare. You can see visualization of a single interstitial portion of fallopian tube in the main uterine body. Gestational sac or product of conception seen mobile and separate from the uterus and completely surrounded by myometrium, with a vascular pedicle adjoining the sac to the unicornate uterus. The management is excision of the rudimentary horn, either through laparoscopy or laparotomy. Ovarian pregnancy. There is no specific criteria for ovarian pregnancy, but usually it's an empty uterus, wide echogenic ring with an internal anechoic area on the ovary, negative sliding organ sign. It is not possible to separate the cystic structure or the sac from the ovary on gentle palpation. Corpus luteum should be identified separate from suspected ovarian pregnancy. Color Doppler may aid detection of the fetal heart pulsation in the ovary, or a complex echogenic adnexal mass with free fluid, which is rupture ovarian ectopic pregnancy. And the management is definitive surgical treatment. Is preferred if laparoscopy is required to make diagnosis. Removal of the gestational products by inoculation or wedge resection. In presence of large ectopic pregnancy is preferred. Inoculation, the birth of conception bluntly from the ovary, minimize damage to the surrounding ovarian tissue. You must achieve homeostasis by electrocautery or by suturing. Oophorectomy is occasionally required when there is a coexisting ipsilateral ovarian pathology or excessive bleeding. However, if the risk of surgery is high, or post-operatively with the presence of persistent residual trophoblast tissue, as persistently raised BHCG level, we can offer the woman systemic methotrexate. Heterotopic pregnancy, in which ultrasound findings demonstrate an intrauterine pregnancy and a coexisting ectopic pregnancy. Serum BHCG level is of limited value in diagnosis of heterotopic pregnancy. Intrauterine pregnancy must be considered in the management plan. Methotrexate should only be considered if the intrauterine pregnancy is non-viable, or if the woman does not wish to continue with the pregnancy. Local injection of potassium chloride or hyperosmolar glucose with aspiration of the sac content is an option for clinically stable women. Surgical removal of the ectopic pregnancy is the method of choice for hemodynamically unstable women, and it's also an option for hemodynamically stable women who would like to preserve the intrauterine pregnancy. Expectant management is an option in heterotopic pregnancy where the ultrasound findings are of a non-viable pregnancy.